I want to talk about problems that arise in this business between people who approach healthcare issues and ethical issues and efficiency issues from the point of view of a clinician dealing with patients, and those who look at this whole issue as a point of view of, say, planners thinking about how to devise healthcare systems for populations, because I think there's a very sharp distinction drawn in many people's minds between clinical perspectives and population perspectives. So I really want to explore that now, and both the ethical issues and some of the data gathering issues that are raised by that. So that's the business here. Right. And I think I have to come back to the issue with which I started, about whether rationing or whether the whole idea of prioritizing healthcare isn't really fundamentally unethical business. And this comes back to not only is rationing inevitable, but do we have the right to indulge in it or not, from an ethical point of view. And I think the contrast is very sharply established between, at least in Britain, very traditional doctors who say that a doctor must do everything possible for the patient in front of him or her, no matter what the costs. That counting costs is not a proper matter for doctors to take into account, and that it's unethical for it to happen. Okay? That's what I call viewpoint A. And viewpoint B is the view that economists and others propound, which is that a doctor should take costs into account, even when making decisions about the appropriate treatment of an individual, okay, of an actual individual. So I want to address which of these two viewpoints is right, and of course it's the second one, just in case any of you are in any doubt. It's the second one. And I think the reason why the positions get polarized in that way is because of a failure by doctors and to some extent by patients to understand what costs are. Okay? What costs are. Now, if you ask an accountant what will something cost, that gets translated into how much money will we have to part with. Okay? And that's the notion of cost that goes into budgeting systems and financial systems and so on. And I think it's very easy for people then to slide into the notion, well, if it's just a matter of money, let's just throw more money at it. I mean, why is money a problem? You can print it. It's just the cost of printing, isn't it, really? That's all it is, and the government can print money. So why are we allowing people to die when all we have to do is to print a few more banknotes? Okay, that kind of thinking. And that's the kind of thinking that accountancy can wittingly or unwittingly promote. But if you ask an economist, what does something cost? The economist translates that into a different question. What will we have to sacrifice? Okay? And that's a very, very different question. What will we have to sacrifice? And it got incorporated into the rather awkwardly phrased term opportunity cost. That is to say, the cost of doing A is what you might otherwise have done, B. Okay? So the cost of A is B. Now, coming back to the resource constraints imposed upon people in healthcare of one kind or another, which may be financial, but there may also be constraints due to time or the availability of physical resources, or knowledge is another important constraint. There are all sorts of constraints upon people's behavior, which mean that when they decide to do X, they have ipso facto, although they may not be conscious, decided not to do Y, which they could have done. Okay? There's always something else you could have done, and you choose not to do it. And the economist's argument that the most valuable thing that you chose not to do is the cost of what you did decide to do. Okay? And that's a very, very important concept which we try to drill in to our students in the first term, the notion of opportunity cost. Now, is that okay? Because this is another one of these simple truths out of which you can get a hell of a lot of mileage. Right, I can proceed on the basis that when I now say cost.
Alan, just
Yeah.
to let you know that Dean of our medical school, Phil Farrell, and the Associate Dean for Administration, Gordon Ridley, have just joined us.
Okay, welcome. You just missed the fascinating discussion about why in future we should discriminate against the old and women in healthcare. Okay, but I have to say we didn't come to a very clear conclusion about it, but I'll try and make this a fun session too. So cost, here we go on cost. So when somebody says to me, you should do the best you can for this person, no matter what the costs, I think to myself, they're saying, no matter what the sacrifices. Okay? If you say we should do the best we can in this situation, no matter what the costs, they're saying no matter what the sacrifices. And the sacrifices, however, are always borne by other people. Okay? So this is not just a matter of efficiency, it's also a matter of equity. I mean, why have you chosen to benefit this person and exclude this other person? Okay, so there is both an efficiency argument, that is to make sure that what you've decided not to do is definitely less valuable from a social point of view than what you've decided to do. Okay, that's the efficiency bit. And also, it's more just that the person that you've decided to offer the benefits for is the more deserving person. Okay? So we have two things going on here. And so no matter what the costs equals no matter what the sacrifices. And I want to know who bears the sacrifices as well as who gets the benefits. Because if you're interested in equity, you have to be interested in who's getting and who's being denied. Not just what is being provided and what is not being provided, but also who. Who. And that is why, coming back to my earlier, that is why viewpoint B is the legitimate viewpoint and viewpoint A is not. I mean, how can it be ethically right to do something no matter what the sacrifices? And I keep on saying people who ignore the costs of their actions are not behaving ethically, they're behaving fanatically. That's what fanaticism is all about. Not caring at all about the costs of your actions. Okay, that's what, and fanaticism in medicine is dangerous, very dangerous, and totally unethical. So I say those people who say that we shouldn't consider the costs are behaving unethically, I would say, unethically. So it's exactly the opposite of what they say. It's not that it's unethical to count the costs. I think it's unethical not to count the costs. So it's totally reverse. Okay. Now, then I asked myself, since this goes back to arguments I was having with British doctors in the 1980s, they've stopped fighting on this particular front at the moment. And but then I thought, well, what is there in the training of doctors that leads them to think like that? And all this business about the doctor-patient relationship being the central element in the practice of medicine and all this kind of thing. So I started looking at the principles of medical ethics. Well, there are lots of different ways of formulating the principles of medical ethics, but I found a particularly valuable version in the Stanford Medical Center document about medical ethics, which is the one I use, but it incorporates the material that's in all of them. Doctors say to me, well, you see, medicine is an ethical profession, but economics, it's not a profession, and its ethical basis is very dubious, okay? So then you put one down, you see. So if you want to argue with the doctor, you're one down at the beginning, because he's busy occupying high moral ground and you're down there in the foothills, you know, struggling to get heard. So I thought, well, I wonder what is the underlying ethical principles of health economics? What are they? Even though we don't blazon them around, what are they? And how do they fit with these principles? Well, these are the injunctions: preserve life, alleviate suffering, do no harm, tell the truth, respect the patient's autonomy. Skip the last one for a moment, I'll come back to that. Just take the first five. Preserve life, alleviate suffering, do no harm, tell the truth, respect the patient's autonomy. That's what doctors are supposed to do if they are to behave ethically. Well, let's just think about this. Preserve life, well, that's fine. That means, in my book, try to extend life expectancy. Okay? Well, that's in my quality calculation, I do that fine. I feel quite at ease with that. Alleviate suffering. Well, that's about health-related quality of life, isn't it? So my quality calculations do that, and they put them together, and they weigh one against the other. Well, doctors have to weigh one against the other, don't they? Because sometimes, in order to alleviate suffering, you have to do things that may shorten someone's life, and so you have a problem. Do no harm. Well, that's tricky, isn't it? Do no harm. Does that mean if anything carries any risk of harming a patient, you shouldn't do it? Well, that's not possible. Almost every medical intervention carries a risk of harming people, and usually it's so small as to be, quote unquote, negligible, unless you happen to be the odd 1 in 1,000 patient for whom it proves fatal. But I mean, so do no harm cannot mean what it actually says. I think what it actually says, what it's actually meant to say, is that you shouldn't do things that you believe will do more harm than good. Okay? You should not do things. And that means that, for example, it's totally unethical for doctors to have anything to do with torture, for example, where the whole purpose is to inflict harm on the individual. So that's totally immoral. But then the rest of it is balancing risks of good and harm. Well, who should balance these risks of good and harm? Should it be the medical professionals doing this? I mean, or should it be the patients who are balancing the risks, these risks? So this do no harm is a matter of balancing risks of costs and benefits, okay, in a subjective sense. And if you remember, and I was quite happy with that, you remember the stuff I talked to you about yesterday about coronary artery bypass graft. I said there's a 3% chance that you'll lose what you would have had in order to get a 67% chance of a gain, okay? So that's balancing of risks and harms, and somebody has to decide whether it's worth doing. So that's all right. I feel quite comfortable with that. Tell the truth. Well, yes, always. But I mean, in a doctor-patient relationship, that's a little bit more tricky. I mean, are you going to lay it on the line, even though it's going to upset people greatly to no avail? Or are you a bit selective about the truth? Be economical with the truth? You try to find out what it is people really want to know, and you only tell them what you know if you think they really want to know. And if you think they don't really want to know, you don't tell them. Okay, so telling the truth has to be traded off against the alleviation of suffering. Okay, so all these things conflict with each other to some extent, and respecting the patient's autonomy. Does that mean that if the patient wants something which you feel from your knowledge and experience they are likely to regret, do you go ahead with it, or do you try and talk them out of it, or you just refuse to do it? I mean, what exactly do you do? If you're subject to resource constraints and somebody wants, you know, the last drop squeezed out, no matter how many bucks it costs, you're going to go ahead and do it? Or are you going to say, well, I've got to draw a line somewhere? So you draw the line somewhere about how far to go. So the respecting of the patient's autonomy is also traded off. Well, when I think about me, what do I do about respecting the patient's autonomy? Well, I've decided that it isn't the patient's autonomy I want to respect, it's the autonomy of the people who are paying for the health service, because so I'm trying to respect the autonomy of the general population. Okay, that's not individual patients. Now that's a big difference, a big and important difference between me in a planning mode and the individual clinician in a doctor-patient relationship mode, because I'm trying to look at the interests of the whole population served by the healthcare system, not just those who happen to be in it at the time, who are the patients. So here, there is a big difference between my stance and the stance in medical ethics, but I'll come back to that in a moment, because maybe even that difference isn't quite as clear-cut as it appears to be. So these first five items here are actually ethical prescriptions that were developed in order to protect frightened, vulnerable, emotionally disturbed, ignorant people from being exploited by powerful, knowledgeable, authoritative people. It's an ethic of interpersonal conduct which tells doctors how they should be behaving in this situation, which is fraught with danger for the patient. And so it's designed to facilitate trust from patients to doctors. That's what those are all about, really. And they are promoted as part of the ethical basis of medicine in order to do precisely that. But the last one is different. Okay, the last one isn't about that. The last one is about fairness. It's about distributive justice. And distributive justice is not something that can be settled at an interpersonal level. It's about how the treatment of one person compares with the treatment of another person. So it is essentially a matter of interpersonal behavior, not person to person, but between people, and has an entirely different basis dealing justly with patients, which I'll come back to in a moment. And that's the basis of equity arguments. Now, the equity argument at a simple form takes the form of saying people in the same circumstances should be treated in the same way. So the doctor shouldn't favour people according to totally irrelevant considerations like, I like this guy, or I hate that guy, or he's a good person and he's a bad person, or whatever. It's a black person or a white person. You should deal justly. That is, horizontal equity requires you to take into account only the things that are relevant from a clinical point of view, and you're not supposed to sit in moral judgments about people otherwise. Now, that's the horizontal equity argument, which I think would be the natural interpretation of what that means in the context of clinical practice. But of course, what is purely clinical and what is an ethical or moral judgment is a bit fuzzy at the edges. For example, is the fact that if someone smokes when you've told them not to smoke, is that, and then you decide that you treat them differently on that account, is that a moral judgment or is that a purely clinical matter? Okay, and so on. Is the fact that somebody is old and therefore their recuperative powers are perhaps not so great, is that a purely clinical judgment that you decide not to give this treatment to people after a certain age? Or is that a matter of equity, that you've been sold on this crazy idea that Williams has about fair innings argument and ageism? I mean, it's sometimes very difficult to detect whether judgments are being made on purely clinical grounds or whether they have moral content. And the history of the development of medicine is rife with issues where doctors have masqueraded behind clinical judgments and actually made quite important social judgments. So this is a real problem, a real ethical problem within medicine about what dealing justly with patients actually means. That what is the proper role for moral or ethical issues within the practice of medicine? Or is medicine a purely technical scientific enterprise with clear boundaries, as it were? Right, let me just pause there before I go on to say why I think even at a clinical level these distinctions don't hold quite as well as they appear to. Is that okay? Okay. Medical ethics, because it involves the weighing of these different characteristics, this source for which I got this is the Stanford University Medical Center Committee on Ethics, stuff published in 1988 when I was working particularly on this. They say because medical practice often brings these principles into conflict, resolving the conflict is central to the art of medicine, okay, they say. Now what that says is that two different doctors, both subscribing to these set of principles, could come to quite different conclusions in an identical case because they might give different weight to the different principles. One thinks the preservation of life is far more important than the alleviation of suffering, and another one makes a slightly different weight to this. And they can both claim to be behaving ethically, and if they're operating within the quite wide bounds of conventional clinical practice, no one's going to question their ethical status of what they're doing. So this is a very loose structure within which to operate. It gives a hell of a lot of discretion for individual judgment. Now, of course, you could say that what the economists are trying to do, crashing into this racket, is to say, well, I don't like having this rather loose judgment, particularly in a system like the National Health Service, you know, where we're supposed to be pursuing national policies. And I don't want to, I've got data that shows that ordinary people think pain is a lot more important than loss of mobility, and they certainly think it's more important than getting back to work. So I don't want these doctors working for the National Health Service struggling to get people back to work and not worrying about their pain. Okay? I don't want them doing that. They shouldn't have that discretion. So I want a set of rules, I want a set of outcome measures used, which they're forced to use whether they like it or not. Okay? So I want to constrain this clinical freedom to interpret these ethical positions as according to how they like it to be. I want them to conform to the norms that I have got good evidence for. I've got good evidence for my norms. They've got no evidence for theirs at all. They're just nice people who have got these thoughts, and I don't want them running private healthcare system at the taxpayer's expense. Okay? If they want to work, salaries come from the taxpayers, they don't want to do it my way. Okay? So that's where I stand. Okay? And of course, that's not a very popular position to adopt. So I don't get a lot of fan mail over this. Now, So let's just go back and ask why it is that doctors in a clinical situation claim this freedom of manoeuvre. I want to distinguish two roles that doctors are playing all the time. They are playing the role of clinicians advising an individual who has come to the doctor with the doctor as a trusted professional expert. Okay? And when you're sitting with a patient, that's what you're doing. But doctors are also practice managers all the time. They don't just have the patient in front of them, they have a whole stack of other patients that they're responsible for. So there are people waiting next in line, or and they're doing this with resources that involve committing other people to doing things as well. So they're not just committing themselves to do whatever they think is best, but they're committing other medical staff, the resources of the hospital, other colleagues, activities. They're part of a network of activities which constitutes a medical practice. And so they're running their professional activities for a clientele. And within this, the more resources they devote to the patient in front of them at the time, the less there's going to be for the others. And this may be at a fundamental level like the doctor's own time. I mean, should I spend 2 hours with this guy who won't give up smoking, browbeating him into giving up smoking? Or do I just tell him in 2 minutes, look, you've got to do something about this, otherwise, this treatment isn't going to do you any good, and then move on to the next one. Okay, where do you stop? Exactly. And you stop, I suppose, by balancing the benefits to this patient at the margin against the costs in terms of the resources that you would otherwise not be able to devote to the others. So you're weighing costs and benefits all the time. And you may see this as risks and benefits, or you may see this as the worthwhileness of the productivity of spending more time with one person compared with what you could do for the next. But however you see it, you're solving an economic problem. Okay, you may not see it as an economic problem, but the economic problem is, at the margin, are the extra costs worth the extra benefits? The classic economic problem. And so what I want to know is, well, which costs are you taking into account and which benefits are you taking into account? It's not that you're not doing it, it's the question, are you doing it properly? Okay? Are you taking into account all the costs that are relevant? Are you taking into account all the benefits that are relevant? So that's what I want to investigate. And this is the doctor still as a practice. Well, I don't even think that at a clinical level, doctors are perfect agents for the individual in front of them. If a doctor, as a clinician, were a perfect agent, the situation would be that, doctor as a perfect agent is there to give the patient all the information the patient needs in order that the patient can make a decision, and the doctor should then implement that decision once the patient has made it. That is the doctor respecting the autonomy of the patient, okay? And that would be the nature of this negotiation that takes place in the clinical setting. It looks like that. Now what I'm going to do is something rather naughty, and I'm going to give you that sentence again. But everywhere there where it says doctor, I'm going to put patient, and everywhere it says patient, I'm going to put doctor. Okay? And now it reads like this. And then what I have to ask you is, does this sound like the typical encounter between a doctor and a patient? Or does the other one sound more typical? Okay? In fact, it's not so much the doctors giving the information to patients so patients can decide what to do. It's more the doctors eliciting information from the patient so that the doctor can decide what to do. And so I think that already, even before we get to the practice manager role, the clinical role is a bit muddled compared with the mythology, shall we say. So I'm not greatly enamored of the mythology, but I think more important is this practice manager. The mythology is based on the notion that the only person the doctor is responsible for is the person in front of him at the time. But I think it goes broader like this. Maybe it goes still more broad. And maybe sometimes the doctor would have to think about whether there aren't people out there who need the doctor's services more than the people who are actually coming. And that maybe we should change the system around a bit so we go out looking for the people who ought to be coming and discouraging some of the people who are coming, even on efficiency grounds, let alone equity grounds. So I think there's a much broader set of issues that move the doctor, even in his clinical role, towards a population perspective. You see, what I'm doing is I'm shifting the ground all the time away from this one-to-one thing towards a broader population base. And of course, different doctors in different situations have a different population. I mean, the British GP has a list of 1,500 people for whom he's responsible in general practice. And he knows who they are. They are listed. And if you ring him up and make an appointment, you say who you are, they pull out your records, you go and you see the guy. And so he knows his. If you turn up and you're not on his list, you say, well, I'm a visitor. You know, I'm in Madison today and I'm not on your list. My doctor's 1,000 miles away. Well, then they'll fill in a form and say they want to know who your doctor actually is. And so then you fill in the form, you go ahead. But it's clear that in general practice, they have a certain circumscribed set of responsibilities. Hospital doctors, it's not so clear. They cover a much bigger population, but they would say they're only responsible for people who've been referred to them by a GP. You can't just walk in and see an orthopedic surgeon and say, I want my hip replaced, please, because you don't get anywhere. I mean, they say, who's your GP? I mean, you shouldn't be here. How did they let you in here? I mean, what's going on? This isn't allowed. So this business about who you are responsible for is really quite important. And I think the population perspective is more pervasive than many doctors think it is, and that medical ethics claims it is. And so I come to this point. Once it's acknowledged that a practitioner has multiple responsibilities to many different people, then ethics requires a fair balance to be struck between their respective interests, and that includes those who are denied treatment need to be considered as well as those who get it, and that's what costs are all about. So that's why I think that what the economists are saying has a really rather stronger ethical basis than the ethics of individual patient-doctor relationship. Has a very strong ethical basis. So I don't have any problems with saying that viewpoint B that I mentioned at the beginning is a really solid ethical position. So So let me just stop there and we'll have a little discussion if you want. Yeah.
I agree that the doctor is also still concerned about the more greater number of people rather than just
Yeah.
the patient in front of them. But when they say, when you say that, then do you mean priority setting or some financial constraint should be made? For
Yes.
doctors?
I'm mostly thinking about priority setting because in the British system, the financial considerations for patients aren't really to be taken into account. They're not relevant. The financial considerations for patients don't really exist.
No, what I mean is not for financial consideration for the patient, but some kind of financial constraint that the
On the doctor? Oh yeah, yeah.
The reason
Yeah.
why I say that is, I think still, if we think about the relationship between a patient and a doctor, it might
Yeah.
be important for a patient to be able to trust the doctor completely, so that the patient can trust the doctor will do whatever they can do for me.
Yeah, okay.
And then if
Okay.
the decision is not from the physician, but from somewhere else, and then
Yeah.
because of that decision, physician eventually having some constraint
Okay,
for
okay.
the care.
Right. Well, now, in the British system, there are explicit financial constraints upon the amount of resources that a doctor has available to them. Now, it may be a group of which the individual doctor is merely one, so it may not be upon him himself, but upon the specialty of which is a part or the general practice of which is a part. So there are financial constraints, and they have a strong incentive to work within them. So the doctors will be thinking about the financial consequences for them, for the practice of what they're doing, although it typically won't be quite in money terms. It'll be how many beds we have or what's happened to our drug budget at the moment. We're being a bit abstemious, so it won't be sitting there with a calculator totting up the costs, because on the whole they've no idea what the costs exactly are, but they will certainly be constrained. And the issue, the ethical issue, which is exercising British doctors quite a lot, is should they come out in the open with a patient and say, well, I could recommend you to have a heart transplant, but let's take these pills, it'll be cheaper for a while, and we'll see how it works out. And if we ever get around to a heart transplant, it won't be just yet, because at the moment, heart transplantation is so costly in relation to the thing that we're actually operating on this drug regime instead. Now, they don't actually say that, okay? They don't actually say that. What they say is, well, the indications are that this drug is the appropriate way of treating your condition at this point. And that's all they say. They don't say, well, a heart transplant is a possibility, or something else is a possibility, or coronary artery. They just don't say it. And the question is, tell the truth? No. I mean, it'll just cause unnecessary distress, and it'll upset the doctor-patient relationship a bit if they think we're giving them an inferior treatment just to save money. But what they're offering is the more cost-effective treatment. Okay? Not the most effective treatment, but the most cost-effective treatment. And that's a real ethical dilemma, I think, for doctors at the moment, because of this telling the truth rule. But then I think since they never told the whole truth anyway, I don't see there's anything new about that. Is that what you wanted?
Yeah,
It's not even what you expected. Okay.
yeah, this, I think my point was, I still think because of, for the better doctor-patient relationship, whatever it may
Yeah.
be, the role of doctors have for the rationing part should be limited by some kind of constraint, and then like the people who think about the rationing more broader term
Yeah.
should be like an economist or some ethicist
Okay.
who can think of the
Okay.
population level.
So you're saying the rationing rules should be devised by people other than the doctors, and the doctors should then just implement them. Is that what you think?
They have some little responsibility, but it cannot be wide.
No, no. Well, I think that's the ideal that the managers in the National Health Service would like to move towards. That is to say, there's some limited clinical discretion, but it operates within strict rules. For example, waiting lists are a big issue in the British setup because the non-urgent, fairly stable situations are just left on the side for a while, and they're dealt with as and when you're able to. So you make sure that all the urgent stuff gets done, and then you fill up the space with the non-urgent stuff. So we have these waiting lists. And the argument, very active at the moment, the British Medical Association has been pursuing this too, that we should have quite explicit points system operating on waiting lists, and so that it isn't left to the discretion of individual doctors the rate at which people come off a waiting list or anything, and partly because half the time it isn't the actual doctors who determine the rate at which patients come off waiting lists, but their secretaries. And so it's felt there's a lot of injustice in this, and it's supposed to be a national system, and we should have national rules. So they say, for example, that you should, when you put on a waiting list, you should be given a points for the size of the expected benefits. You should accumulate points for each time you wait, and then doctors should be given a little bit of discretion about giving a few extra bonus points to people if, for example, they should come off a bit more quickly if the condition is having a serious effect upon their work or their family life, so beyond a purely clinical. So, for example, hernia problems for manual workers get priority over hernia problems for sedentary workers, and maybe you give people a few extra points if you know that the waiting time is about 6 months, but these people are going on holiday then, so we'd like them in either a bit later or a bit sooner or something, something like that. So, a bit of clinical discretion, and there's a discussion going on at the moment about how much clinical discretion individual doctors should have in using these bonus points. So that's a very clear instance of where this is being made quite operational about taking people off waiting lists, the rate at which people are taken off waiting lists. But I think it's extremely difficult because the indicators for treatment are not normally that precise. They're a bit vague, and even things that you think are really rather good type measurements, like the measurement of blood pressure, got pretty big margins of error associated with it. And if you wanted to manipulate a point system, you do your blood pressure measurements in a particular way, and away you go. So I think that inevitably there's going to be discretion at a clinical level, no matter what you do. It's inevitable.
Yukiko, I think, is the point she makes in your response is so relevant right now to us, maybe even more than in the UK, in the managed care world, because the financial incentives are so, we don't acknowledge kind of socially we have rationing, but the R word, everybody knows that in these situations, the constraints are there. And the fact that they're being implied externally and without a rational agreement on the outcome measures and the points and the rationing process, in many patients' minds, doctors then would, matter of fact, maybe, depending on the capitation, or maybe making the rationing decision on a patient-by-patient basis in their own office, perhaps with financial incentives, and that's what's kind of undermining the trust. I think some people are viewing that if there is rationing, if it does have to happen in some ways it ought to move to a higher level in which the doctor can still be the patient's advocate as strongly as possible, but within the rules that are sort of set, I think, in a way that you would argue for, in a bit more with clinicians as managers or taxpayer citizens or payers sort of working this out. But right now we've got multiple different people making multiple different rules, most of them not necessarily in the social interest. So it's a total jumble, and this lack of trust between doctors and patients is really an epidemic right now. I mean, as we speak, this year, next year, last year, I mean, it's really coming unraveled. So there's got to be a rationale, whether this way of thinking is the rationale, or whether some other thing will happen before it melts down. I don't know, but it's a very acute issue right now.
Well, the formal bridge at the moment is the creation of evidence-based guidelines, and that's the thing that people are hanging on to. They say that we should have evidence-based clinical guidelines, and we've recently set up a new national body called NICE, wonderful acronym, the National Institute for Clinical Excellence. Okay, I mean, who can argue against this? And then in brackets at the end, after clinical excellence, it has and cost effectiveness. in very small print. Okay, it says and cost effectiveness, and of course there's a struggle for power going on, which the economists will certainly lose, between the medical profession and the economics profession, if you pardon the expression, about whether these guidelines should be guidelines for clinical excellence, that is effectiveness only, or whether they should be guidelines for cost effectiveness. This cost effectiveness, of course, the economists are saying it's got to be cost effective. This is ridiculous. The NHS is not in the business of clinical excellence. It's in the business of cost effectiveness. And the managers know that, even the population knows that deep down. And so we're about to witness, over the next couple of years, how that shakes out. And if it does what it is supposed to do, and there's no guarantee that it will steadily create cost-effectiveness guidelines for all the most high-profile activities that are on the margin of medical care, and this margin will slowly. It'll dig more deeply. And one of the arguments at the moment is that its terms of reference have been so set up that it's likely to finish up applying quite stringent criteria to new things, but it won't actually look at the old things that need weeding out. And I think it'll have to shift its ground into questioning a lot of the things that already go on in order to create space for new things to take place, because we operate within a fairly static budget. So I think we're going to face this in a very clear institutional way without ever having resolved the underlying issues. Yes?
I wanted to ask if you could comment on the dilemma that's faced by an individual doctor or a group practice or a healthcare delivery system when the costs and the cost effectiveness is not known with enough precision that you can factor it into your medical practice, whether it's for an individual patient or a group of patients or for a population. In fact, I think that's one of the major difficulties. Doctors don't really know, in this country anyway, what it costs to do this or not to do it.
No. Well, you're more likely to have such data than we have, because you bill people for things. We don't ever bill anybody for anything.
But we don't know what they pay.
No.
When you
No.
practice from day to day,
Yeah.
you don't know what's being paid and who's paying it.
No.
Typically.
No. Now, well, I think there are several issues there. I mean, one is I've talked in what I've been saying. I've talked more about benefit measurement. I've said very little about cost measurement, but that's another snake pit. I mean, what sort of costs to whom? Which. You see, you have multiple payers. We, to some extent, have multiple payers in the sense that there's a borderline between hospital care and primary care, they run through different budget systems, okay? The money comes out of the same pot, ultimately, but it's handled by different people, and they each have their own budgets, and they're thinking about how to do the most cost-effective thing from the point of view of what's on my budget. So, for example, when the hospitals had a big squeeze on their pharmacy budgets, instead of giving patients when they were discharged from hospital enough drugs to keep them going for a week, they sent them a little letter to the GP and let the GP provide the drugs, telling the GP what was to be provided, but actually it came out of the GP's budget, so they do a bit of cost shifting, you see. Now, that's a bit dangerous because it may be that this communication system doesn't always work perfectly. The patient goes home for 2 or 3 days before they actually lay hands on the drugs, and that shouldn't have happened really. And so you're getting the system put at risk at the margin by individual bits of the same system operating on quite narrow definitions of costs. And it's also been argued that early discharge from hospital is the way the hospitals shift costs onto primary care or onto the patients themselves. And so from a social point of view, you really don't want to do that, but then who's got the incentive to rejig the system? What should be happening? We experimented for a while with the health care system having a tranche of funds called joint funding, whereby the healthcare system could pay local authorities to provide nursing and other support for patients discharged early from hospital, because the local authorities didn't have enough money to provide the support, and the hospitals didn't feel able to discharge people without more support, so hospital beds were, as they said, blocked by patients for whom medical and nursing care was no longer strictly necessary, but social support was very necessary, but there was none of it out there, so the hospitals could pay people to do it. And so should hospitals be entitled to pay helpers in the community to facilitate this transition between hospital and home? Well, we did that for a while, and then we stopped. I think it's a pity we stopped, but we did stop. And it's particularly a problem for us with the elderly and the mentally ill, where we've, as a matter of principle, tried to get these people out of institutions. So the margins of across boundaries are a really severe problem for us. So it's not only that people don't know enough to be able to respond sensibly, which was your point, but even if they did know, they still might not respond sensibly because they don't have any incentive to do it. So we have two problems. We have poor knowledge and poor incentives in the system, and well, we've been grappling it with for a long time, and we haven't resolved those problems yet. We probably never will resolve them completely, but I'm sure we could do a better job than we're doing at the moment. We have a special commission on long-term care at the moment, which is trying to grapple with this borderline between medical care and social care, which is, as I said, a growing problem for the old and the mentally ill. That's a big problem, and we haven't solved it. Right, any other points to be thrown in at this point? Okay, I'm almost at the end, you'll be glad to know. I want finally to go through a few points that have emerged from particularly from some philosophers, people like John Harris and others, about the ethics of all this, and what the consequences would be, what the implications are of different ethical positions that you might adopt. And there is an argument emerging in the philosophical literature that it is simply wrong for anyone to sit in judgment on the value of somebody else's life. And it's argued that that's what all this quality stuff leads you to do. You're really saying that an extra year of life for an old person is worth a lot more than an extra year of life for a young person. That's what I'm saying with the fair innings argument. That's what it says. It's making social judgments, ethical judgments about the value of different people's lives. And it said that this is a very obnoxious thing to do, that it's an unethical thing to do, because society should have an equal duty to everybody to preserve life, and this shouldn't depend upon the length of their life or the quality of their life or anything like that. And John Harris in particular argues that the rest of a person's life is the unit, not their whole lifetime, but the rest of their life. And we don't ask, so long as they wish to go on living, everybody has an equal right to the rest of their life. That's what he says, and that's his. And if you take that position, then all this quality stuff is out, because the quality stuff based on the notion that we are discriminating between the rest of people's lives according to how long it's going to be, how good it's going to be, how good a life they've already had, how long a life they've already had. So we're taking in a lot of detail about personal characteristics, and we're sitting in judgment on it. Okay, whether we like it or not, that's what we're doing. And so he says that the only fair way to resolve these dilemmas, given the fact that we have resource constraints, is to have a lottery. Okay? When the time comes, it should be a lottery, because that's the only way we can avoid making these invidious judgments between people. So the lottery becomes a very big thing in this literature. I think it's absolutely ridiculous, but then I wouldn't I? I think it's ridiculous for two rather different reasons. First thing, I do not think that you show respect for people by making important decisions about their lives through a lottery. Okay, that doesn't seem to me a very respectful thing to do. So his desire that people should be shown equal respect doesn't seem to me to be fulfilled by telling them that, I've listened to what you have to say, and there is something we can do. And just a minute, I've got a table of random numbers here, and too bad. Okay, that doesn't seem to me a very respectful thing to be doing towards people. And so that's one reason why I don't like it. But the other reason I don't like it is that, in fact, lotteries have to be structured. Okay, now, what is the nature of this lottery going to be? Are we all going to have an equal chance of getting a heart transplant, whether we have heart disease or not? I mean, what do you have to do to enter the lottery? Okay, there's a set of rules. You enter a lottery, you have indicators. You'd have to have a set of indicators for the lottery, wouldn't you? You'd have to say, well, if you've got heart disease and we've diagnosed you've got this now 1% of the people in this category are going to get heart transplants, and 90% are going to get this drug, and 9% are going to get nothing. Okay? Now we're going to enter, this is the lottery you're now in. Okay? So you go into it, and it comes out that you're going to get nothing. Well, can you come back next week and enter it again? Or is this a lifetime decision that you've made? I mean, exactly what are the terms of entry into this lottery? Are we going to say, well, you can't enter this lottery if you're still smoking, okay? Or you don't enter this lottery if you're 90 years old, or whatever. So you've got to actually confront all the issues that John Harris is anxious to avoid when you're structuring the lottery. You know, they don't drop from heaven, these lotteries. They're created by people. And then there would be a lot of argument take place about whether this is a fair lottery or whether this is the right lottery. So we then have a big public policy discussion about the structure of these lotteries, which is what he was trying to avoid in the first place. So I really think that this is just plain ridiculous, okay? But it doesn't stop it being pursued. And there are quite a lot of philosophers who think you can avoid moral issues by creating lotteries, and I think there's an escapist streak in them which needs to be stamped out. So that's the first point. I don't know if anybody wants to defend lotteries, but as you gather, I don't think much of them. Well, the next thing that people say is, okay, it's okay to compare benefits, but it's not okay to consider costs. Well, I've dealt with that at some length, so I don't think I'll go through that again. I mean, costs are simply foregone benefits. Okay, that's all that costs are. So the notion that somehow comparing costs is different from comparing benefits is just wrong. I mean, the benefits go to one lot of people, and the costs, that is the foregone benefits, go to another lot of people. And it seems to me that everybody who's affected by a decision has a right to have their interests considered, which is why I always go for the general population rather than the population of current patients. But there's another argument which I think does need to be addressed, and that is many people get very upset by this obsession with numbers and counting things, and I'm an obsessional quantifier. You know, I want to make even matters of social justice, turn them into numbers and weights and things. And many people think that once you start measuring things, you've somehow dehumanized some fine humanitarian concept like justice or something. I mean, how can you turn it into a set of numbers? Or should you turn it into a set of numbers? And I think this is a quite deep psychological problem in our civilization generally, and not just for individuals, but generally, because I observe that if on television you see some named individual who has been denied something or ill-treated or hurt in a road accident or something, you think, God, how awful, and you know, the relatives are there and you have a very clear picture of this person. But if you get a set of statistics that 340 people were killed on the roads in Wisconsin last month, or whatever the number is, well, okay, pass on. Okay, 345 people, that's a lot of people, but I mean, I don't, you know, how do they collect these statistics? Where they come? But these 345 people are these same people you saw on television only 345 times. So you should care 345 times as much about the statistics as you did about the pictures on television, but we don't. And you can tug people's heartstrings by showing cases on television, and you'd have a hell of a job tugging their heartstrings by giving them a thing with a whole stack of statistics in it about numbers of this, that, and the other. So what's wrong with us? I keep on asking myself. There must be something wrong with us. Why don't we have what I would call statistical compassion? Okay, we don't have it. We have individual compassion, quite strong. Statistical compassion is extremely difficult to generate. And of course, and for people like me who are pathological counters, as it were, of things and measurers of things, this is a real problem, because I know that years of careful research can be destroyed by one television program which presents one anecdote that works against my general argument, and my general argument is shot to hell. I mean, I've lost. Because you get one nice tearjerker that works the other way, and I think this is a really big problem, and I don't know the solution to it. I've struggled with this no end, and so I'm still pursuing my notion that we need to engender statistical compassion, we need to make ethics more quantitative, but I've got a nasty feeling that I'm on a losing wicket here. What do you think?
I think the trend has been in your direction. We didn't have follies 20 years ago. I think people are much more interested in those things now. You're absolutely right. You can be destroyed with one TV commercial, but think the overall trend has been in the direction of accountability.
Yeah.
On the other hand, I think the people who say that quantification is not the only measure have a lot behind that as well. My training as an anthropologist, you can learn people have an awful lot of things, important things about them that you cannot measure.
Go on, name one.
Well,
Well, for one thing, you can count things. You can say how many people believe this compared with how many people believe that.
oh, but their beliefs change. And they
Okay,
believe
so we'll
different
count
strongly.
that.
Your question, I
And-
can ask the same question you asked 30 different ways and get 30 different answers.
Yeah,
You
right.
can't measure that.
And you just mentioned 30. You
Well, yeah,
just
but you
mentioned
can't-
30. Yeah, but you see, you see, it's interesting because I'm involved in a project at the moment which is about focus groups and getting focus groups of representative samples of citizens to talk about fairness and whatnot. And I've got a colleague who's crazy about this kind of thing, and I'm very dubious about it, but we're still working together on this project. And at the end of the day, I'm saying, well, what are you going to do at the end? Are you going to tell us a whole stack of little fairy stories about this and that, you know, what X said and what Y said, and have this little dialogue like bedtime stories for children? Or are we going to start saying, well, this issue arose 35 times compared with that issue, which only arose once? And that's what people at the end of the day do in order to say how much weight you should give to the different positions, don't they? And even anthropologists count things, don't they?
I think it's very helpful to count, and I'm all in favor of your general argument. However, if you ask a person right now what they would trade off,
Yeah.
it'll be very different from what they would have traded off yesterday, and extraordinarily different once they actually
That's
get into that
testable.
position.
That's
It is
testable. And I've tested it, and the sort of things I do, they don't change from week to week.
Well,
You know, their attitudes towards pain versus disability versus getting back at work do not change quickly. I mean, they might change slowly, and they change at different points in the life cycle, but you can pick that up, of course, cross-sectionally. So, but I mean, all those things are testable. I mean, even if they were unstable, you test them by counting things. So as I said, I'm a crazy counter, but I doubt there's very much that you cannot count. Even aesthetic matters, which I think are at the extreme. You can count the number of people who think this is beautiful versus the people who think that's beautiful. You can still do it.
You know, Bruce, oh, sorry.
Oh, I was just going to ask whether you thought this was an either-or proposition. You know, I mean, you could make I could imagine a situation where story and anecdote moves people in a different way than quantification, and there may be room for both, depending on what it is you're trying to accomplish.
Yeah, but you're talking about political persuasion now. I mean, there are two elements in this, aren't there? One is how you try to represent reality, okay? And that's a very awkward issue. And I'm saying I'm more convinced by representations of reality which count things and present statistical data. And I'm quite happy with that way of representing reality. Many people are not happy with that way of representing reality. So, and some people deny there is such a thing as reality. But anyway, but there's a second issue, which is, suppose I've worked out in my mind what would be the best thing to do according to these various principles. The next thing is, how do I persuade other people? Now, it may be the best way to persuade other people is to put the statistics on one side and get a whole stack of sob stories that are all on my side and not on their side. But you see, that's not science, that's marketing.
Well, but you know, I've talked to you about I agree with Bruce. I think it's moving into your direction, and not just in health, but in other fields, in the environmental standards. We're getting more comfortable with that because we're having the national debate about education standards. But I think, you know, people are beginning to say, you know, you can't. I mean, we got to have something to move to, particularly as so I think it's in that direction. But I do. I mean, one of the I mentioned briefly that we were considering breaking down summary measure into a life stage approach, and you know, part of that has to do with some measurement intuition. But frankly, a lot of it has to do with politics as well, and the qualitative parts of it. I mean, I think you can maybe hook stories to the kids' measurement, the working population's measurement, the older person's measurement that appeal to those interest groups that also support the statistics in a way that the sort of general thing, in my experience in the last 2 years back here, the general thing has a lot of trouble gathering, kind of support and identification on a technical ground and on this not being able to relate to it. And finally, on your point, I think it probably depends on, people can change, but I think it depends on whether you're applying at an individual level or whether this is sort of used at a population level for resource allocation. At a population level, there's probably, and again, it's a power question, but there's probably a lot of things that sort of people go up and down, but differences across groups to some degree can get washed out if you're really talking about qualities across larger groups than individuals. But I think it's going your direction, but I think you're going to have to hook the humanity into the measures in order to have the measures get more public acceptance.
Okay. Yes.
Betty Crocker for Uruguay, that's what you're saying.
Yes. Well, you see, I appear on television programs in Britain quite frequently because they want to wheel somebody up who has these unbelievable views about things, and that any rational person can actually stand up and say these things, like we should discriminate against the old. I haven't actually stood up and said we should discriminate against women yet, but it'll come. And what I try to do with the television presenters before I appear is I say, look, we really want, can you set the thing up? They always go to hospitals and film things, and say, can you set it up in such a way that the viewer is presented with a really tough choice, okay, that you could do this or you could do that. So it isn't give these people something or just deny them, because denial is inhumane. I mean, the only thing that makes denial humane is the fact that it's in the interest of some greater good. And unless you present the allegedly greater good and let people think for themselves, you don't really present the problem as it appears in reality. It's extraordinarily difficult to do that because it's very difficult to see who precisely benefited from some denial. The people who got something are not rushing to the newspapers complaining or saying how good it was or anything, but the people who are denied something are. So it's quite difficult to find them. It's also difficult to put the population, the general public, in the situation of thinking about whether we should put money into care of the elderly or the care of children in a way that's realistic. When I published my piece in the British Medical Journal about why we should discriminate against the old, the Help the Aged and Age Concern, which are two big pro old people pressure groups, had just published a report on the prevalence of age discrimination in healthcare. The implication being that it's all wrong. Okay, it shouldn't happen. It does happen, and there's no doubt that it happens. But they were documenting where it happened and saying it was bad. Same week, the Child Poverty Action Group, okay, another pressure group whose purposes are obvious from their title, produced a report indicating that something like 15% of children were being born into families where poverty was such a problem they were likely to find themselves malnourished, their health prospects were poor, and so on. And I thought to myself, God, what I would like to do now is to put these two groups of people together in the same television program and let them arguing their case. Okay, that would have been really good if we'd have got them. But I know what would have happened at the end of the day. The television presenters would say, obviously, we should spend more money on healthcare so we don't have to face these problems anymore. Because that's what they always do. My experience is they always finish up there. Okay, they want to run away from the problem. Yeah, right. Early on, I went round you and asked you what it was you really wanted to talk about. And I'm just quickly looking through to see whether I've missed anybody. Anybody's had a raw deal. Anybody feel they've had a raw deal, that things they wanted to talk about didn't get talked about? Because now's your chance in the last few minutes to make sure it gets talked about. Dissatisfied customers.
I'd be interested to see if anybody got off the bandwagon. And, yeah, well,
Yeah.
Off of it or not? Off the thing.
Yes. Which bits of this cause you the most disquiet? Let's put it that way.
The only one that I have is that I still, even though the U.S. spends 2.5 times more per person and is clearly wasting a goodly sum of that, there will indeed be more capacity to benefit discovered through research. My biggest problem with it is we are spending half of our national budget on something that destroys life and quality of life, i.e. military,
Yeah.
and huge amounts on other things that destroy quality of life, like overuse of automobiles, overuse of plastic, etc. You know,
Yeah.
when a huge proportion of the economy is spent decreasing life extension and quality of life, I think there's still some room to maneuver on capacity to benefit in the long run.
Okay, well, I won't comment on that. I mean, this is I would say that if, I suspect, as I do in the British situation, with us spending only 6 or 7% of a smaller GNP on healthcare, compared with your, what's your 14, 15% now? I can't remember where it's got to. Yeah, 15% of a much larger GNP per head than ours. I suspect that in Britain, if you're really interested in improving people's health, I wouldn't spend the money on the healthcare. So I don't think it's an argument for spending more money on healthcare. It may be an argument for redirecting social policy generally towards improving health-related quality of life, which is a different issue. Okay, but so I don't think the resources devoted to things you don't approve of, and if they were released, I wouldn't think that it would be good buy for you to put it into expanding healthcare. Anything else anybody would wish to, anybody who feel very uneasy about?
Can I just confirm one thing, just to see if I got this right? Is the fair innings argument your response to the question how to distribute QALYs in light of societal concerns of equity?
Yeah,
That's right.
that's what it is, yeah. Yeah, it's one equity, one important and I think very pervasive equity notion is to reduce inequalities in health, and it's encapsulated in the fair innings argument. Yeah.
Do you feel like you have enough, since your fair innings are going to run out one of these days?
Me, personally, me now, yeah.
Do you feel like you have enough disciples out there that the movement will proceed?
Well, you see, I think that what happens in the British healthcare system at the moment is that age discrimination does occur. It occurs on both efficiency grounds and on equity grounds, but people feel the need to be very secretive about it, and they're very defensive about it. And I want to stop them feeling defensive about it and feel willing to be open about it on the grounds that I think it is justified to do it. So, and perhaps to do even more of it than we already do. So now, whether I don't imagine there's going to be a great bandwagon rolling in this direction, because the politicians are busy denying that age discrimination of any, that nothing is ever done purely on grounds of age, they say. We're not purely on grounds of age. Well, what does that mean? Does that mean that chronological age is not the important thing? Because in my argument, chronological age isn't the important thing. It's your life history that's the important thing, but it so happens, and your life expectancy. Your life expectancy isn't purely a matter of your age, although that's the best predictor is your current age, but it's due to a whole stack of other things as well. So I think there's a little bit of weaselly words going on at the moment. When you say we're not going to discriminate purely on grounds of age, I could say, well, I'm not advocating that. I'm not advocating purely on grounds of age.
Actually, my question had more to do in general with you quantifying
Quantifying.
benefits in your quality just of life years.
Well, I think I think it was you said that things are moving in this direction. I think it would have been impossible. I started in on this game nearly 30 years ago, and with I think I told you jokingly about my index of crime seriousness, which I then turned into an index of illness seriousness. And at that point, the medical profession was affronted by the notion that you could put numbers on these things. Since then, there's a big move towards outcome measurement based on quality of life and whatnot. It's become big business. So the whole world has changed in the last 30 years, and I hope it'll change in the next 30, because I'm not at all happy with where we've got to. I can think of all sorts of things we could do better than we do at the moment, and I'll be very disappointed if, in 10 years' time, people didn't look back on this and say, God, that was primitive stuff. I mean, how did anybody ever think that was worth struggling with? Okay? I'm hoping that it's changing. I was very disappointed when I started looking at the care of the elderly in 1970, that I'd worked on this subject of the economics of caring for the elderly for just 12 months, and I found myself being invited to international conferences as an expert on the subject. I thought, God, this must be a terrible subject. If you can become an expert in 12 months, it's ridiculous. Okay, well, I've now been on these subjects for 30 years, and maybe I should now be regarded as an expert, but I'll be very, very disappointed if what I'm doing hasn't been overtaken completely in another 10 years' time. Just a little historical footnote. Right, so there I am, Dave. I'm a historical footnote. I'm still on my feet there. That's my lot.